I think that's my cue that we're good to go. So welcome everybody to this evening's webinar, which we've titled Da Vinci Urologic Surgery Over a Decade of Clinical Value. I'm Peter Black. I'm a urologist at the University of British Columbia in Vancouver. And we have with us this evening our keynote speaker or guest speaker, Dr. James Porter, and also a panel. We'll start with Dr. Porter speaking, and then we'll follow it with a panel discussion. I'll introduce our panelists a little bit later, and then we'll end with some questions and answers. Next slide, please. Just a reminder, for those of you not too familiar with Zoom, which is hard to imagine that you would not all be very familiar with Zoom, for questions, please enter them in the chat function. You can click on chat, which you'll see in the bottom of your screen in the middle, and then type in the question over on the right side. You can just send it off to everyone, and we'll tabulate those and address them during the Q&A later on. Next slide. Just a little bit of background on robotic surgery globally and in Canada. You can see in this graph that over 8.5 million patients have been treated with robotic-assisted surgery since it was started back around 2000. Urology was leading the way initially, but you see a lot of the other specialties such as general surgery have really had a major uptick in more recent years. Number of patients treated robotically in 2020 is 1.25 million. So you can see the vast increase in numbers over time. Next slide. In Canada, it's been a bit of a slower, more gradual rollout. We have in Canada treated almost 45,000 patients with robotic assisted surgery since 2003. We have 200 robotic trained surgeons across the country, and we have robotic programs in the most populous provinces, in 5 provinces, 13 cities, including Quebec, Ontario, BC, Alberta, and Nova Scotia. Currently 29 hospitals have a robotic program, and 3 of those hospitals have more than one robot. This is like a big city in the US, Jim is thinking, but next slide. Just a little bit about my own robotic background. I learned robotics as a fellow. I have to say I did my first touch of the Da Vinci was with Jim as a resident. He let me sit on the console for about 30 seconds. And then as a fellow, learned it and have been doing it in Vancouver since 2008. Do especially prostates, of course, and we still do a lot of open prostates in our system. And I don't overplay the value of robotics, but I think it's clear that I tell my patients less blood loss and a quicker recovery are the big things. The disadvantage for us is a long wait list for robotic surgery compared to open. I think it's made a big impact also in partial nephrectomies, which I previously did laparoscopic, which I also learned from Jim. And now I do them all robotically, and I feel that I can do the more complex ones robotically that I would previously have done open. Next slide. And so it's my pleasure at this point to welcome Dr. James Porter, who's a world-renowned robotic surgeon. He's always been on the leading edge of robotic surgery and pushing the envelope. Jim is a urologist at Swedish Medical Center in Seattle. He has already performed over 4,500 procedures, which is a remarkable number. Primarily prostate and kidney, but one of the areas that he's really been on the leading edge is with the retroperitoneal lymph node dissection for testis cancer, and also reconstructive surgery. So Jim is medical director for robotic surgery at Swedish Medical Center in Seattle, and also the director of robotics for Providence Health and Services. And I know firsthand that he's a fantastic teacher and mentor, and spends a lot of his time dedicated to promoting the art of robotic surgery around the country and around the world. So welcome, Jim.
Thank you so much, Peter. It's really a pleasure to be here. And I really want to thank you for the kind introduction, and it's great to connect. All these many years ago, the first time I met Peter was actually in Mainz, Germany, I actually had dinner in his apartment with his wife, and he was a student there. And this is prior to coming to Seattle. It was a great meeting, and I knew right then he was going to be somebody to reckon with in urology. And it's really great to watch what he's done at UBC and the career that he's created and all the people he's helped. And it was actually my pleasure to be a part of his education. And I really thank you for the opportunity to be here. And I want to thank the group from Manoj and who's invited me to be here to talk to everyone about kind of where things are south of the border in robotics. And I know, there's a pretty big difference in the way we see things with regard to healthcare. And I was looking at your slide of the number of robots in Canada. I thought that was very interesting. I have 6 in my hospital, 6 robots in just my hospital. And we have 53 in the Providence system, which is more than you have throughout Canada. So, it's very different, but more is not better always. And I think what we need to do is we need to use this resource, and it is a resource, at least in our hospital. We need to use it wisely, and we have to be careful that we're not using it without the correct intent. And I think what I've seen in the Canadian experience is a very good kind of measured approach to this technology, because it is expensive, there's no question, but I think it has significant benefit for my patients. And that's what I want to talk about tonight is what is the benefit of this technology, and what is the evolution in robotics really allowed me to do as a surgeon, and how's that benefited my patients. So I'm going to talk about the Vinci Xi, which I know is not a common robot in Canada, but I think there's definitely some benefits on the horizon for those that don't have it, and address some kind of how this differs from the SI. What are some of the limitations? How this really improves my access to the abdomen and allows me to be more efficient as a robotic surgeon, which is, I think, we're all interested in spending less time in the operating room. I think the big issue for me is that the XI has allowed me to expand what I'm doing with regard to procedure complexity. And I think I'm very interested to hear Peter's perspective on partial nephrectomy. I think that's really interesting to hear how he's now taking cases he would have done open and now doing them robotically. And that's been my experience as well. I think what I'm doing now robotically would be very challenging to do laparoscopically. And I know there's great laparoscopic surgeons in Canada, and I'm familiar with many of them. And I did a lot of laparoscopy, but I think I can do what I'm doing now with the robot better than I could do laparoscopically, and actually do a better cancer operation, preserve more tissue, better quality. So for me, there was actually a ceiling on what I could do with the SI. I think I reached that ceiling, and without further improvement in technology, I was going to be limited to what I could do. But I think the XI has done that, and it's allowed me to expand what I can offer as minimally invasive surgery to my patients. And I think that's the ultimate goal here. I don't think there should be a dichotomy between what a patient who has, say, a complex problem and a person who doesn't, and then the person who doesn't have a complex problem gets MIS, and the person who's got a complex problem doesn't get to benefit from a MIS. I think we should be striving to do that, whether it's laparoscopy or robotics. I think MIS should be able to offer to all patients, where we can. So I want to focus a lot about what the differences are between the SI and the XI, and then I'm going to give you 3 kind of use cases with regard to the XI: partial nephrectomy, Nephro-Ureterectomy, and then RPLND, which Peter alluded to is a big interest of mine. So a little bit about my training. I was a predecessor to Peter at the University of Washington as a resident there. And actually, when I was in Germany doing my fellowship is, I think, when I met Peter. And I learned to do laparoscopy there because there's really no laparoscopy happening, at least in the Northwest at that time in the United States. So I went there to learn laparoscopy. Then I was on faculty for 10 years at the UW, and I was the head of laparoscopy and robotics. And then in 2005, I went to Swedish and performed, quite a number of mainly prostates and kidneys, but we do pretty much everything here. I'm not a big fan of cystectomy, so we don't do that robotically. I've been involved in teaching and training for many years, so I'm currently training my 18th fellow. So we have a fellowship that I've been very proud to maintain, and really I think we've created some really outstanding robotic surgeons. And then, as Peter mentioned, I direct the robotics program for the entire Providence system. 53 robots. You know, we have over, you know, 300 to 400 surgeons that are involved in robotic surgery in our system. And I would be remiss if I didn't mention that I'm actually have been instrumental in training some Canadian fellows. And these are some folks that you may recognize. These were all excellent young men to work with, very knowledgeable, smart, and it was really great to have them. So I think I've been able to hopefully infuse some robotic MIS knowledge into this group, and I really enjoyed the whole experience with the Canadian fellows. It was awesome. But I want to talk a little bit about how the technology has evolved, because as you look at the different generations of the robot, what you see with each one of the generations is an improvement in every aspect of the tool. So the optics have improved, the ability to reach tissues has improved, the type of energy and the precision of the energy has improved. Now, as we talk about the fourth generation, there's things other than just tissue cutting that you can do. There's, you know, stapler that you can use. There's fluorescence imaging, which allows you to see perfusion and vascularity. These are all things that have been added as time has gone on. And so, you know, it's very interesting about, you know, this is not really an ad for Intuitive, but, you know, they didn't really have to make the robot better because they've had no competition, but they did. Every generation, they made the robot better. And to me, that's a credit to them. They understood the importance of this tool for what we do, and they have made this a much better tool each time they've created it. So I'm going to talk about three main differences between the SI and the XI. And the first difference is docking. And I'm going to start with docking because docking allows me to kind of go through a little history. And the history is that I'm going to show you my first robot. This is at the University of Washington. I think Peter was there around this time. This is a 3-arm standard robot. So this was my first robot. It was amazing compared to laparoscopy at the time. We really thought it was incredible to be able to do robotic surgery versus laparoscopy. And I was really excited, and it got me going in a direction that's obviously changed my career, changed what I do for my patients. In 2006, we got the 4-arm standard at Swedish. That's actually Herman Kwan, the fellow there from Canada. He's there at the bedside for one of our first retroperitoneal partial nephrectomies in 2006 using a 4-arm standard robot. In 2007, this is the Vinci S, and there's Jeff McCracken giving direction for docking. And that's our transperitoneal approach using the Da Vinci S robot, again, before the SI. Here's the SI in 2011, getting ready to dock between the legs for a prostatectomy in 2011. And again, this technology was a major advance, more reach with this robot versus the SI. And now here we are, the current model, the Da Vinci XI. And I want to show the boom here because the boom with the XI it rotates. And so it gives you more flexibility with regard to where you can bring the robot from. And that makes a big difference depending on your room. If you've got a small room, you can't just dock it from one position every time. And so I think what the XI boom has allowed me to do more variation with docking. It's allowed me to do different procedures that I could do with the SI because I can approach the patient from different angles. So more freedom of movement. It works great in smaller ORs if you have a small OR. And it's allowed me to do more what I call side docking versus inline docking. With the SI, you had to dock kind of in line with the arms because there were arm rotational limitations. With the XI, because of the ability for the boom to rotate, you don't have to be coming in from a fixed position, which makes a big difference. So here's, for example, when we do a retroperitoneal partial nephrectomy, we can dock from the front, we can dock from the foot, or we can dock from the back. And we choose to dock from the back in most cases because our assistant's in the front, but it gives us lots of flexibility. We don't have to move the table around. I remember with the S and the XI, if we wanted to dock over the back, we had to turn the table 90 degrees. We had to move the anesthesiologist had to move their machine. It was quite a hassle. Now the bed stays in place, the robot moves, the boom moves because it rotates, so it's much easier. And here's our RPLND. SI, we came in over the head. Anesthesiologists don't like it when you come over the head. With the XI, we can come side dock, and this is how we're able to get the robot in to do the supine approach for RPLND. Gives us a full bilateral approach. So port configuration is quite different with the XI. But the big advantage here is that the robotic XI arms are actually narrower and longer. And because they're narrower, there's less external arm conflict, and you can actually put the ports closer together. And this has significant implications for the type of patients that you're working on. So if you're working on children possibly, or teenagers, or small patients who have a very small footprint, if you will, the XI really lends itself to that, because you can bring the arms as close as 4 centimeters together as far as distance. If we try to do that with the SI, we would have continual external arm conflict, and the case just would not go well. Because of these arms and the ability to bring them in tighter, this is giving us more flexibility. So, for example, when we did the transperitoneal partial nephrectomy with the SI, we only had enough space for 3 robotic arms. There just wasn't enough room for the 4th arm. However, with the XI, because you can see how tight we can get the arms together, I use the 4th arm on every XI case. And why is that helpful? Because the XI is a great aid for the robotic surgeon, because it makes you less dependent on your assistant. You have another arm inside the body that can help with retraction. So you don't need to you don't have to have another assistant port for retraction. It also increases the effective range of the robot, because by putting that extra arm in place, you can reach to areas that you just couldn't reach with 3 arms. You can retract the bowel, you can retract the kidney in many cases, and overall it improves your exposure. The other nice thing about the 4th arm is it's fixed retraction. So I know when I did laparoscopy, I had an assistant like Peter on the retracting arm, and it did, that it wouldn't always stay in place. And sometimes Peter would get tired and there would be whining. And of course we didn't like that. So now with a robotic arm holding it, it works quite nicely. We don't have to worry about anybody complaining. Let me show you the difference between the SI for retro. So with again, because of the space limitations and the arm size, we could do a 3-arm approach with the Da Vinci SI. With the XI, because the arms can be brought together, like I said, between 4 to 6 centimeters, you can do a 4-arm approach in the retroperitoneum. This point alone has really changed the retroperitoneal approach in the US, because I would say before the XI, the retroperitoneal approach was more of a curiosity, I would call it, because people just found it very hard to be in that small space and not be able to retract. And with the 4th arm now, I think this has really gained, it's allowed retroperitoneal approach to gain a lot of popularity, and it's been able to be done safer. And so I think this has really expanded what we can do. So this is what it looked like with a 3-arm approach. Here it is with a 4-arm approach. And because of this, we can expand who we're offering the retroperitoneal approach to. One of the kind of relative contraindications to doing retroperitoneal surgery early on was obesity, because you just didn't want to wade through all that retroperitoneal fat. And if you didn't have an arm to help you retract, then you had a hard time seeing. But this is patients now that we do. This is a patient with a BMI of 54. You could see the incisions there on the side. That's a retroperitoneal approach for partial nephrectomy. She did very, very well. Again, patient with BMI of 60. You can see the incisions on the side. These patients do very, very well. And actually, they carry most of their weight in front. So going on the side, we found retroperitoneal is actually an advantage, because you're going through actually a thinner portion of the abdomen to get to the retroperitoneum. Here's a patient who had a total colectomy. So this patient, you would love to avoid the scarring and adhesions from a colectomy. So you can go retroperitoneal on this patient. Before the XI, we probably would not have chosen to do this robotically. We probably would have chosen to do this open, because we couldn't have gotten that space. But now we were able to do this patient with the XI because of the ability to get 4 arms in place and do the operation safely. And then the complexity of tumors. And I think this is the big difference with partial nephrectomy now, especially for me with the XI. Here's a Bosniak 4 cyst, 6 centimeter tumor, a nephrometry score of 10P, a very complex tumor, but again, did this retroperitoneally, 9 centimeter tumor, again, very large, very complex, did this with the XI, no issues, and a very central tumor here. So almost in the center of the kidney. This would be an open procedure in most cases, if not a nephrectomy in most cases. We can do this kind of procedure robotically with the XI, again, doing the retroperitoneal approach works extremely well. So what about the arm reach? How has that benefited what we do robotically? Well, the XI instruments actually have an increased reach of about 4 centimeters. So just over 4 centimeter difference in reach between the XI and the SI. That doesn't sound like a lot, but when you're trying to get down deep in the pelvis for a very obese prostate, that can be the difference between reaching the apex and not reaching the apex, depending on your ports. Because that you have that extra distance, you can also bring the ports farther away, which is also very important for obese patients, because, you know, one of the ways you deal with obese patients in the pelvis is you want to bring the ports down lower. If your angle is very steep because of the large abdomen, you get that big poochy abdomen, you have a hard time reaching. But if you're too far back to try and get a shallow approach, you can't reach the organ. So this increased reach has really made a big difference on what we can do. It's expanded essentially the area that we can reach in the abdomen. Another feature of the XI, which is very unique to the XI, which is not seen on the SI, is something called the clearance joint. And if you're familiar with the SI, you can reach pretty far going forward, but if you try to go backward on yourself, the robotic arm will actually it'll reach a limit where it can't go back any farther. So you can't go back in underneath yourself, so to speak. So there's a back limit, if you will. What they've engineered with the XI is the ability to rotate the robotic arm out of the way of the instrument. And what that does is it allows you to go backwards further. So you actually gain the underneath direction, if you will. And this has we didn't think it was a big deal until we started to do things like RPLND and Nephro-Ureterectomy, where we figured out that the ability to go backwards made a huge difference on what we could do. So this is what it looks like with the arm kind of in its normal configuration. And then when you take the clearance joint, you rotate it out of the way. So there's my assistant behind there. What you can see is the arm's being rotated out of its own way, if you will. That allows the arm to go back even farther, and you can reach back underneath yourself. So let me show you some of how these advances have really improved some of the operations we can do. So I want to show you a case here of a 75-year-old female who was discovered to have a 4-centimeter tumor in the left kidney. This was discovered incidentally, of course, as most tumors are these days, and had a history of breast cancer, but otherwise has done well and has not had recurrences. So here's a CT scan. There's the axial view. You can see the tumor in the left kidney there behind the hilum, kind of a challenging location. And here's the coronal image. Again, focused on the left kidney here. You see the tumor coming into view. It's essentially right in the center of the hilum, right behind the vessels. So let me show you another technology we're using. This is not part of Da Vinci, but this is a 3D model, and 3D models are gaining a lot of traction when it comes to improving the imaging and quality that we get from CT scans and MRI. So these 3D models actually take those DICOM images, fuse them together, add color, add definition, and you can see the tumor location here better than you could. You can add things, you can take things away. So we can see that tumor is very close to the renal hilum against the ureter. So this is going to be a challenging partial nephrectomy. So we're going to do this retroperitoneally. I'm just showing you the position. The patients are in the full flank position for retroperitoneal approach. The idea here is you need to open up the space between the 12th rib and the iliac crest to create enough room to get the robotic robot in place. And here's our 4-port configuration using the Da Vinci Xi. We use a 12mm assistant port using a device called AirSeal, which allows us to really maintain high flow. And that's really good in the very small space of the retroperitoneum. So we like AirSeal for this application. So I'm not showing you the whole procedure. This is an edited video, but I'm showing you one of the techniques that I really like to do. This is a vessel going to the tumor that we've actually just, like you would old school, put a silk around it. And then we clamp the hilum, and now sped up video showing you our excision. And you can see this tumor is intimately associated with the main artery. That's a branch coming off the artery. And we're going to carefully peel this tumor off the artery and vein. And again, excellent visibility with the retroperitoneal approach, but also with the XI. We can see things that you just really can't see because of the magnification and this excellent 3D image with high definition. So that's the tumor removal, just showing you the rhinorrhaphy very quickly here. Hilar tumor, we tend to do more of a selective rhinorrhaphy, closing the deep layer with individual sutures, and then the cortex with the sliding clip technique. So let me show you a little bit about our experience with nephroureterectomy. So nephroureterectomy we did with the SI, and we really felt there was a big benefit of using the robotic approach for nephroureterectomy, say over many of the techniques that have been described for handling the bladder cuff, whether that's done endoscopically or it's done separately as an open procedure where you do a Gibson incision, go in and take out the cuff. That's definitely an option. But we were really interested in doing this all robotically if we could, again, because of the benefits of staying in the abdomen if we could. And so we did this with the SI, and there were descriptions by other investigators with how to do this with the early robots using a single trocar configuration. These were very small series, and they really didn't work in patients who had any sort of obesity. And it did require kind of a combination between laparoscopy and robotic, so it wasn't a pure robotic technique. And then there was a technique where they would actually put a metal port inside of a plastic port, and then they would run current through it, and that would set up the potential for what's called capacitive coupling, and that's something you'd like to avoid. So none of these techniques that were described were perfect. And so what we did with the SI is we actually had it, we kind of broke the procedure into two different parts. We had the kidney portion, and we would actually use this, we thought about the triangle, if you will, the kidney triangle, the left arm, the right arm, and the camera, and then our direction of the surgery would be towards the kidney, so that direction. And then for the ureteral portion, we'd actually have to redock the robot, so that means disconnect it from the patient, and then we'd bring it in front of the leg, and then we would use this triangle, if you will, with the fourth robotic arm as our ureteral portion, and then direct our dissection down in the pelvis that way. So that's what the port configuration was like. What it looked like from the outside is docking the robot over the back for the kidney triangle portion, and then, like I mentioned, undocking and then bringing it in front. So cumbersome, doable, cumbersome, but you still really never got the same exposure that you really wanted with this. But it was we were able to struggle through and get it done. With the XI, this has changed everything because, as I mentioned, the reach that you have, the extended instrumentation reach and length, the ability to go backwards on yourself, and the fact that these arms can be placed in such a way where you don't have to be as good, I would say, with the XI when it comes to port placement. You have to be super precise, I think, with the S and the SI. But with the XI, you don't have to be that good to get the case done. But what we've been able to do is a fully single port, single docking Nephro-Ureterectomy, doing the full bladder closure with a bladder cuff and an RPLND, of course, at the same time. And this is what it looks like. So it's more of an angled linear configuration. So angled towards the pelvis, if you will, opening it up towards the pelvis. And that allows us to do kidney, ureter with the docking over the hip. So we dock right over the hip, kind of halfway between, and that allows us to get into the pelvis. So here's what it looks like in real time. Got our Varus needle in. There's our 4 ports. We have 1 assistant port near the belly button. And this is how we're going to do the left-sided case. So let me show you a case we did with the XI, a 54-year-old male with chronic kidney disease, so declining EGFR, presented with gross hematuria, and on CT scan was found to have a very central kind of fungating tumor within the left kidney. And if you did a few more scans, you figured out this was not your normal kidney. This was actually a horseshoe kidney. So we see tumor in the left moiety of this horseshoe kidney. And ureteroscopic biopsy was performed and confirmed high-grade TCC. Patient was given the option of chemotherapy, but his creatinine was actually not very good, and so there was concerns about that. So he did not get neoadjuvant chemotherapy. Negative metastatic workup, and fortunately, the left moiety, when we did renogram, was actually the worst of the 2 kidneys. So we were going to be basically removing the lesser of the 2 kidneys, which was hopefully going to not impact renal function any more than it had. Again, so this is our port configuration, and so here we are inside. So here we are showing the kidney. So we're down a little lower in the pelvis. This is the ureter we've identified. We're tracing it down into the bladder. So here we are. We've got the bladder cuff, and I put my suture in, about as soon as I make the initial incision. So once you make that incision, that hole sucks far, far away. So we put that suture in there first, so we don't lose that handle, if you will. After the closure, we test it to make sure it's watertight. That's what we're doing here, filling the bladder. And now we're bringing ultrasound in. This is robotically controlled ultrasound with the ProGrasp. And we're looking at the isthmus of this horseshoe kidney. And we're just identifying where it meets the other moiety. And there's, so you can see sit over the aorta. That's the aorta on the ultrasound underneath the isthmus there. And then we think this is where the connection is. And now I'm going to use Firefly to determine which vessels I have to take. So I don't want to take any more vessels than I have to. So I clamped the vessel going to this area. I gave this indocyanine green. You can see with the near infrared camera, the green tissue. And now I'm going to come off there, and you see that vessel clearly perfuses that portion of the kidney. So we know we have to take that vessel. We were hoping to save that vessel. We were trying to save as much as we could, but we know based on where this moiety ends, we need to take that vessel. And that's how Firefly really helped us to see that very clearly. So we've got, basically, we're doing this without ischemia. We've basically taken the vascular supply to this moiety, and now we're just going to close this to make sure there's no bleeding. The right moiety is fully perfused. We haven't affected that at all. And then, again, just closing this little isthmus here like you would if you were closing a renal parenchymal partial nephrectomy. And then we end this with the RPLND. So again, with the ability to go back and forth, we have excellent visibility. We spend our time, doing a very clear RPLND, taking off these hilar and periodic lymph nodes, and you can see vision and the lymph node removal is quite controlled. No issues with bleeding, and quite happy with that type of exposure. So procedure took about 3 hours. Patient went home the next day. Turned out to be a very high-grade tumor with invasion into the renal parenchyma. Took out 27 lymph nodes. All were negative, so it was a T3 tumor. And on postoperative EGFR check, it was 28. So lost some, but still not on dialysis, doing fine. No evidence of recurrence. So I want to kind of finish with a procedure that I really have a lot of interest in doing, and that's the RPLND for testicular cancer, both primary as well as post-chemotherapy. And I started doing this, actually I started doing this laparoscopy at the University of Washington, and then transferred to the robot, which was a great way to go because we had a challenging time controlling bleeding laparoscopically with this procedure. With the SI, this was definitely a benefit over standard laparoscopy, but we weren't able to reach, because of the limitations I mentioned before, we couldn't really reach the vessel from the renal hilum to the inguinal canal. And of course, you have to remove the cord stump. And so we had to redock at the end of the procedure to remove the cord. So not a big deal. We could keep it robotically. We didn't make an incision, but it wasn't ideal. And we really couldn't reach as far north. We couldn't really go super hilar if we had to. With the XI, as I mentioned, because of the extended reach, the ability to go backwards on itself, and this is really where that clearance joint really makes a giant difference. When you move that arm out of the way, you can really go backwards, and we can go all the way back, single docking to the inguinal canal, get the cord stump out without having to redock, and so this has been a big benefit for us. Again, just showing you how that additional reach works for us. So as I showed you earlier, the SI was more of a fan configuration with a camera in the middle. The XI is more of a linear configuration. And again, we're starting in the lower abdomen and we're directing up. So I do a supine approach, so I can go from ureter to ureter without having to flip the patient. So historically, when we did these laparoscopically, we did them lateral. And if we had to do a bilateral dissection, we had to re-prep and drape and flip the patient. And that was not ideal. Or you could be very risky and try to get the other side from the other side, but you're working in a very deep hole. If you had any bleeding, it was really trouble. So I like the supine approach, better exposure, allows us to do the real operation, which is to go bilateral if we have to. Again, with the docking, as I showed you before, the boom rotates, so you can dock from that side, you can dock from the other side, or you can dock from the foot if that works for you. So you have a lot of flexibility. So the case I'm going to show you is a 21-year-old male who was discovered on orchiectomy to have embryonal carcinoma and had elevated tumor markers. And this is the pre-orchiectomy CT scan. You can see a rather large mass in the right renal hilum. And this is on coronal. You can see it sitting right over the hilum on the vena cava. And so this is a 4.4 centimeter right renal hilar mass. Patient received 3 cycles of BEP chemotherapy. And you can see a nice response with regard to the markers. And then CT scan, you can also see a nice response. You can see a decline in the size of the mass. You start to see some normal anatomy. And on coronal, again, just giving us a sense that we can see this where this tumor actually interfaces with the vena cava now. So the mass is now 1.9 centimeters. And our approach in this is going to do a bilateral RPMD with nerve sparing, supine approach, again, using Da Vinci Xi. And again, this is our approach. So this is our port configuration. And it's linear. I kind of mark out the obliterated umbilical ligaments just so it kind of avoids the bladder. We rotate the boom around until we have the location that we need, and then we're docked and ready to go. So here we are. There's vena cava. There's the left renal vein you could see there for a moment, And now we're working on the pericaval, basically to the right of the vena cava. And this is the residual mass right there. That's the fibrotic mass. There's the kidney to the left of the mass. So we're going to dissect this off the surface of the kidney and the renal hilum. So dissecting it there, a bit of fibrosis there. This is a connection between the tumor and the vena cava, almost like a small projection, which we were able to peel away from the vena cava. And here we are peeling the mass off the anterior surface of the vena cava. That's basically the right renal vein. We've got a small opening there, but we never worry about things now with, it seems like with the robot, we can control that bleeding without much problem. Yeah, it's a little more than usual, but for whatever reason, controlling bleeding with the robot is much different than what it was laparoscopically. And again, I think it's given us a lot more comfort doing these procedures. So we've got the mass pretty freed up now, and we can see we're above we're kind of suprahilar here above the renal vein, and have no problems reaching here, no problems with visibility. And that's the freed mass. So we'll bag that and then proceed with the rest of the procedure. Just show you kind of what it looks like after the removal. There's the right kidney, there's the renal vein, the IVC. So, you know, we've done the mass removal, but we're not done. We're going to do the full nerve. We're going to do the nerve sparing. And these are the trunks. I mean, this is just remarkable. I think I've never saw these trunks like this with open surgery, but there they are. There's the postganglionic fibers, as you can see, coming under the vena cava, going to the hypogastric plexus. So nerve sparing is definitely doable with this robotic approach. So obviously a long operation. There's a lot to do the surgery there, but patient does very well. Went home the next day. That's basically our standard. They do extremely well, get back to their activities quite quickly. Patient had teratoma in 2 of 21 lymph nodes and actually had normal ejaculation, had a good result from the nerve sparing. So I want to finish with kind of something that's, I think, been of interest of ours, especially with COVID, and that's how we're able to approach getting patients out of the hospital sooner, given the concerns about being in the hospital and what COVID has really done to kind of shine the light on that. And again, I think this is really facilitated by our experience with the robot. So as 2020 rolled along with the pandemic, you know, we were seeing fewer hospital beds available due to the increasing number of COVID patients. There were concerns about exposure from our patients, and they were the ones that were super motivated to not be in the hospital. And if they could get out of the hospital sooner rather than later, they were very on board with that. This concept actually is not new. This was actually pre-COVID. This is actually an abstract from the 2019 AUA. This is the group out of Columbus, Ohio, Ronnie Abaza's group, who was looking at doing same-day discharge for prostatectomy. And when they looked at their series of their last 246 patients, almost 50% of the patients were able to be discharged the same day. They did have a couple readmissions the same day and a couple readmissions the next day, but you know, that's a very small percentage given, you know, what you're trying to do here. And when they looked at the last 100 patients of that 246, 65% of those patients were able to go home and stay home the same day. So that got us thinking about what are we doing? And so we looked at what's our real discharge with prostatectomy. And so before COVID, our mean length of stay without any kind of pathway or trying to get people home was 0.7 days. So the vast majority, I mean, a handful of our patients go home within less than 24 hours. That might be the standard where you guys are as well, but that's pretty much what we've seen, and at least that's what we can do with the robot. Interestingly, when we looked at our partial nephrectomy data, our mean length of stay for partial nephrectomy, I thought was actually quite small. I mean, less than 2 days for a partial. I think that really sets the bar at a new place with regard to, you know, upper abdominal surgery. This is actually how we got that data. This is a review we did and published in 2019, comparing 281 retro partials to 263 trans. These were all matched cases, matched pair analysis. And what we showed in the analysis is that the retro gave us shorter console time, shorter total operative time, less blood loss. I'm not sure why, but also shorter length of stay. And we think the shorter length of stay, although not clinically significant, we saw patients just eating sooner, drinking sooner, and they were more willing to get out of the hospital sooner with the retro approach. So, but overall, if you consider both trans and retro, you know, most of our patients go home the day following surgery, and you know, 2 days is rare in our hands. So again, I think that speaks to the technology. It speaks to what we can do with the robot. And I think this is, you know, for the kidney, this is a big deal. So what did we do going forward in 2021? So this is our pathway. So we looked at, you know, what's the best way we can get the patients out of the surgery. So let's say we get out of the, you know, OR just like late at 11:30. They spend an hour in the PACU and make sure everything's ready to go. Patient goes to the floor, and they're going to spend a few hours on the floor looking to see how they're going to do, and gives them time to kind of wake up, you know, evaluate how they're feeling, what their level of pain is. We also do their teaching, you know, there for the catheter bag, because they're going to have to learn how to do the catheter. We've also started to do that pre-surgery as well, so they're familiar with it, so they don't have to do it while they're drowsy. We get them out of bed usually, you know, at 3:30, second ambulation, see how they're doing. Let them take liquids at 5 o'clock. You know, reiterate the Foley teaching, and then they're evaluated by the surgeon. If they look good, they're discharged home. And we've been able to do that, you know, with this pathway. We've been able to do this about 30%. This is a relatively new pathway, so we're looking to see how this goes going forward. Now, there's some issues here, and I think one of the major issues is the socialization of this concept, because not every patient is going to be, you know, interested in doing this. I would say about 30% of my patients actually come from far away to have surgery with me, and that may not work for them, because they may not want to go to a hotel, which is where they're going to spend the night if they leave. So some people, if they're from out of town especially, they may not want to leave. But that being said, I think we're seeing an increasing rate than we have in the past. So we're interested in pushing this forward, and I think for prostates, we're looking at this, and there's a chance that we might do this for retroperitoneal partials, because our patients, I think, are waking up, you know, and doing well. One thing I'll add that we have done with this as well is we've added something called a tap block. A tap block is where we inject a Marcaine type local anesthetic into the layer, the transverse abdominis layer, if you will, as a way to improve the anesthesia of the port sites. And we think that's made a difference for our patients as well. So with that, I'd like to just to conclude, and I really want to thank you for your attention. I think what I've found, at least with the XI, is it's offered me significant benefits over the SI. I think it's allowed me to really increase the type of procedures I can do with regard to complexity. And it's really allowed me to kind of get through that ceiling I was reaching with the SI, allowed me to do more things. Again, I wouldn't say this is where you're going to start, what I'm doing, but I think what it shows is what's possible. And I think that's what this technology really allows you to do is, you know, in the right hands with somebody who's motivated, I think with this technology, you can do great things. I think it's allowed me to offer MIS to more of my patients. And I think we're very interested to see how this is going to impact our length of stay, which in the US is a big deal. Length of stay is one of the ways we can actually decrease the cost of the robot. So we're going to continue to push this going forward. So with that, I want to thank you from Seattle. Thank you so much for your time and attention, and really looking forward to answering any questions you might have. Thank you so much.
Terrific, Jim. Thank you for that overview and sharing all your experience and insight. I also have new ammunition to go to the hospital to finally get the XI. We're still working on the SI. But at this point, I would like to introduce the panelists, and we're going to do this a little bit differently. And the panelists are actually going to introduce themselves and describe a little bit their robotic experience. So Howard, why don't you start?
Sure, thanks, Peter. My name is Howard Evans. I'm a clinical professor at the Royal Alex Hospital that works within the University of Alberta in Edmonton. I did the full evolution of urologic surgery, where I was trained as an open surgeon. And then under Michael Hobart and Eric Este, was trained in laparoscopy, and then while in practice, developed robotics. In Edmonton, we've been doing robotics for almost 14 years now. We started doing radical prostatectomies. I now use it for radical prostatectomies as well as simple prostatectomies, pyeloplasties, and partial nephrectomies. And we do partial nephrectomies, both trans and retro as well, even though we are still working with the SI system.
Eric?
So I'm Eric Hyndman, a urologist in Calgary. Like Howard, I trained in Edmonton, did my residency up there, and then went down to Baltimore. Did a little bit of laparoscopic prostatectomies in residency, and then some in Baltimore, but most of my experience with prostatectomies and partials has been on the robot. Been here in Calgary 10 years now, done about 700 prostates and then fewer partials. Did dabble in the cystectomies a little bit, but then I just couldn't find a use for it with the robot, and switched a little bit back to open for the cystectomies. So happy to be here to answer questions.
And over to Chelsea.
Hi, everybody. My name is Chelsea, and I'm one of the registered nurses that works at the Rockyview Hospital in Calgary. I'm actually the urology resource nurse in our department in the operating room, and I've been doing that job now for 7 years full time, but I've been working with the robot since we got it 10 years ago. And I just want to thank you guys for allowing me to participate in this panel, because I hope I can give you guys a perspective of how a cohesive nursing team can help facilitate an efficient and accessible robotics program to help decrease setup times, increase case volume, and decrease the cleanup time between our cases.
Thank you, Chelsea. Yeah, and there's a lot to be learned there for sure. So when we start, just a question, and I'd ask the panelists to keep answers relatively short because time is getting away from us here. But maybe a question to our two Albertan surgeons, Howard and Eric. With COVID-19 hitting and there being a real challenge for all healthcare resources, and I think in general we still struggle even without the pandemic resource-wise. How have you been able to use sort of the advantages of quicker recovery, decreased length of stay with robotics and minimally invasive surgery to sort of combat the resource issue, and what have you guys done in an innovative fashion in your hospitals in this regard? Maybe Eric first.
Sure. I mean, it's actually the same thing as trying to get the patients out quickly for cost. You want to try and get the patients out quickly for exposure in the hospital, and then also hospital resources, not only in the recovery room, but also in the ward. So the faster they can get home, the less they're going to be exposed to staff and patients, and then also the less they're going to expose staff. With these complex surgeries, if you can do them minimally invasively and use the robot and have less complications, then there's less risk of going to the ICU as well. And that was one of our main pressures, months ago. It was just the ICU pressure, so beds in the ICU.
Yeah, I mean, I'll echo what Eric had to say, Peter. And as Dr. Porter said, COVID has sort of pushed people, or actually motivated people to kind of want to leave the hospital. We were motivated before COVID to try and get people out of the hospital, and we're pushing that to get patient turnover, to save in-hospital costs. By doing it, we've been able to get people moving faster. And the robot is a benefit. It's minimally invasive surgery. It allows you to do things that you wouldn't be able to do open. And the whole idea of having minimally invasive allows people to go home quicker. But it's education too, and it's education of patients. It's trying to teach patients what expectations are, and having them aware of what discharge is going to be like when they do plan to leave. One of the moves in Edmonton and in all of Alberta now is trying to start with virtual hospitals too, which may help with patients going home and getting contacted virtually by nursing and physician care.
Mm-hmm. Okay, and for Jim and Chelsea, you both been involved in the business for a long time now, and have done a lot of cases, managed a lot of cases. We always talk about the learning curve, and I think Jim can speak to the surgical learning curve, and I think Chelsea can speak to the learning curve of efficiency and setting things up properly. How has your team's approach changed from your initial cases to, say, your 100th case to your 2000th case, or Jim, your 4000th case? And if there's one thing that you would share with a new surgical team, what would it be? Jim first.
Oh, I was going to say ladies first, but I think the thing I would share, at least with the surgeons, I mean, I think that this is really a team sport. I think you hit the nail on the head. I mean, you really have to approach this with people around you that are dedicated as much as you are to doing this well. And you can't do this on your own. I think consistency is extremely important to build a team. We found that to be a really good way to decrease the variability of these procedures and actually become more efficient. So I think what I tell my team is that, you know, we need to do whatever we can to make things as streamlined as possible. So we've gone a long way to look at our instrument trays to decrease the variability there. We don't want to have people doing new things all the time. Our mantra is the same way every time. That's the way we approach these operations to the best that we can. For the surgeon, especially new surgeons who are starting out, they need to understand this is going to be done best if you are dedicated to it, and the longer you dabble at it, the longer the learning curve is going to be. And for some, it's going to be frustrating to never really cross that threshold where you're going to feel comfortable. So I think you really have to dedicate yourself to it, but I'm going to leave my answer short.
Chelsea?
Yeah, and I think when we started 10 years ago, I was a student nurse in the OR, and I remember we were all learning together. Like everything was a process that we did for the first time together. We were just trying to get around the fact that we now had a robot at our site and what that looked like. But as time went on, I think we grew together, we became confident as a team. And then we were just able to streamline our cases, deal with more complex procedures, do the troubleshooting on our own, and then anticipate kind of what the next steps were. In the fact that now we do a training course every 6 to 12 months, and we keep our team small so that the nurses can have as much exposure in a short amount of time for our cases. One thing I wanted to share is I really would love everyone to have confidence in their nursing team. And if the surgeons can be clear with us what your expectations are, I really think it helps us plan ahead and the flow for the room and anticipate if it's a more difficult case or kind of our standard procedures.
Okay, terrific. Maybe back to Howard and Eric. So Alberta has, as Howard said, you know, Edmonton has led the way with robotics in Canada, and I think had the first system and has had the greatest numbers of cases. And so you have well-supported, well-established programs, and I think other provinces have struggled to get hospital support, government support, you know, leadership support. And so over the last 10 to 15 years, Howard, last 10 years, Eric, how have you approached this with your peers, your hospital leadership, and your foundations to gain the support to you know, how have you demonstrated the value of the Da Vinci surgery to get that support?
Go ahead, Howard.
Yeah, I mean, Edmonton, you're right. We had a couple of guys really lead the forefront in Mike Hobart and Eric Estee bringing this forward. And it really becomes a sort of you have to look at robotics program as sort of a three-pronged, where you have initiation, which if you get your foundation involved, it's a sexy thing to fundraise for, and so they're behind it. But that's just the initiation, and that might be the easiest part. And the next part is your development. So getting your team, as Chelsea pointed out, having the right people in your team, having from anesthesia to nursing to administration, all support and be on board, including your OR leads. And then it's the hardest part is the third part, and that's the ongoing support. Having other departments buy in. Initially in Edmonton, it was easy. That's when oil was high and we were loving life. As economies become reality lately, sometimes it can be a little harder, and people look at cutting costs, and all of a sudden you have the question about, well, you know, can you do that any other way cheaper than robotics? And I think the important thing that we did going forward was said right at the beginning, no, this is a better operation. We feel we can do it better. So this is the way we're going to do them all. And that's how they're all done now in Edmonton. Everything is done robotically because that's what the pace was, and that's what was set forward. And the same thing is becoming that way with partial nephrectomies now. So that's kind of the way that we pushed it forward.
Yeah, I mean, fundraising for the robot itself is reasonably easy. Like Howard mentioned, it is, you know, everybody wants to buy that. It's a very interesting tool. I think selling it to the administration or the government, you have to go a little further. Obviously, the ongoing costs are quite expensive, but What they're not very good at is splitting up buckets of money. So if you're saving money on transfusions, which nobody looks at, or at hospital time, I think it's very important to bring that to their attention. So you may increase your budget in the OR, but if you're decreasing your budget on the ward or with transfusions, they need to be aware of that and the cost savings that are there. And then the other thing that we don't think about, certainly in the public system, is how quickly patients can get back to work and how they can get back to work or back to their families. And it is for sure quicker with the robot. I mean, we pick the partial nephrectomy. There are massive differences in recovery between an open and a robotic partial. So bringing that to their attention, I think, is very important.
Right. Those societal costs are so hard to measure. So my last question for Chelsea and Jim. One of the things that we've certainly struggled with, I don't know how it is for Eric and Howard, is getting more than 2 cases done a day, more than 2 prostates or more than 2 partial nephrectomies, whatever it might be. And so what are some of your key practices that your team has implemented to achieve better efficiency in the OR and get more cases done?
I think Chelsea could start. That's a good Chelsea question.
Chelsea first. Yeah.
Yeah, I have a list of a few things, and I'd be surprised if Dr. Hyndman knew that we even did all these things behind the scenes. We do run our robot 4 to 5 days a week and 2 to 3 cases a day. So we come in prepared. Like, we know when we're having those 3 case days. We also staff accordingly. So we try and staff a junior, an intermediate, and a senior nurse, just so everybody's learning needs are met throughout the day. We encourage staff to come prepared. I want them to read about the case. I want them to know the preference card and the surgeon's case notes. We actually try and look up the patient ahead of time from one procedure to the next and go talk to them during one case so that we can quickly bring the patient in the room for our next procedure. We also look at the case cards to streamline all the equipment that has to be open. And as mentioned, we also have standard robotic sets that are used for all of our cases. It just allows staff to be familiar with what's on their table every case and allows for a quick setup. And everybody has a role. It definitely is a team sport. And when everyone's on time, helps position the patient, helps transfer the patient, that really does save us a few minutes. And my colleague and I are always working on the surgeon's preference card. It'd be surprising how many times they like to add little things to their pick lists and make sure that we're on top of their surgical game in terms of what they want to have ready. And we also, the biggest thing too, is we work with our booking clerks to try and book the procedures, same-sided procedures or the same procedure, just so we're not having to take the robot down and put it back up. And also the urologists are a great group of people that we work with at the Rockyview. They're open to communication from the nurses, and that way we're just able to talk to them about, certain things about the case, what equipment they want. And I think we run a very good team. So
I'm muting here.
Perfect. I don't know what happened there, but Chelsea, I might need you to talk to my charge nurse. But Jim, any lessons from your side?
Not really. I think she covered pretty much the things that we all would try to do. But I think having the team. I mean, obviously, turnover is where you can make up the ability to do 2 to 3 cases. And we just, we're not great at it. I can tell you that. There are hospitals that are better than we do it. So we, it is a struggle because sometimes there's new people, and I guess, that this is a complex tool and it's a team that needs to do it. So, we're working on that as much as anybody, I think.
And Chelsea, when you started your program, how many nurses did you have on the robotic team?
When we started, it was still a small group, but we kind of had to expand so that we could capture cases running late. I'd say we probably had about 10 nurses that were part of our team. Now we rotate 20 nurses through our robotics room. That doesn't mean they're full-time and they're always there, but we do try and work on their strengths. Like if they're more comfortable with one part of the procedure, one part of the room, we put them in that role just so that they're more comfortable with kind of how the day flows.
Okay. And then just Jim, thank you for answering the one audience question in the chat. There's one more I just posed to you. It's not a robotic question, but for your nephroureterectomy, do you give intraoperative or post-op intravesical chemo?
Yeah, we do. Yeah, we've been giving the gemcitabine intraoperatively. We really try to empty them out. We don't do it. We do it pre. We're doing it before we get in, irrigating it out, and then hopefully that's decreasing any kind of tumor in the area.
Because it looked like you do your ureter first. You do the bladder cuff first.
Yeah, we do. Yeah, we like that. And the reason for that is that when you take the kidney down, you lose tension on the ureter, and we found the ability to pull the ureter out to be much better when it's on tension. So we actually go do the ureteral portion first, close the bladder, and then go do the kidney.
And do you put the chemo in then after you've taken the cuff, or even before that?
Before. Yeah, we do it at the very beginning of the operation. Let it sit there for a while we're docking, and then we wash it out several times.
Okay. Good. Well, I think for the sake of time, I think we have to call it a day there. Thank you all three panelists and Jim for your input. Thank you, Minogue, for sponsoring this event. And Minogue has a whole series of other webinars coming up, and you can use whatever your QR scanner, whatever it's called, to get the QR codes off of this slide if you like, and then you can follow Minogue on the different social media platforms. And the next slide is also a QR code for filling out a survey regarding this session to let us know your feedback. And with that, I'd like to wish everybody a good rest of your evening, and hopefully to our panelists and Jim, hopefully we'll see each other in person sometime soon.
Thank you so much. Appreciate it.
Bye-bye.
Yeah.